the modification of a site based upon an enzyme on the cell surface. And that brings it inside the cell where it can essentially hijack our own cellular machinery to produce progeny for the virus, millions and millions of viral particles. This receptor site that you see here and depicted over here is called the ACE2 receptor site. And you probably heard of that because we have drugs that can interfere with ACE1 for treating blood pressure. And here's a picture of the viral particle right here. Here are the proteins that come off of the viral particle called the spike protein that attaches to these ACE2 receptors that you see here. And it attaches to that. And once that happens, this virus is brought inside the cell where it replicates. So that's about the end of the basic science for the day. But I wanted you to have an appreciation for what the virus, how the virus gets inside of us and multiplies. A big question is SARS-CoV-2 evolving? Is it changing? And the answer is yes, but the more important question is by how much? Early on in the pandemic, there was a strain called the D614G strain. And it accounted for, in January, all of the cases we saw here in the United States and most of the cases around the world. In February, we started to see the emergence of a new strain called the D614G mutation. It represented a 1 amino acid change in the genome of the virus. So not much of a change, but there was something about that change that allowed it to outcompete the original strain. And now it is the predominant strain of the virus that's causing disease around the world. There's no evidence that this strain is more virulent, that is, it makes us sicker than the other strain, but it does suggest that this strain is more communicable than the original strain. I'd like to say a few more things about the evolution of this virus. This is an RNA virus. Viruses come either as RNA or DNA in terms of their genome. This is an RNA virus. And RNA viruses are notoriously able to have lots of mutations. They mutate rapidly. Think about influenza, which is also an RNA virus. One of the fortunate things for us is that this particular RNA virus does not mutate very rapidly. There are some reasons for that that I'll be happy to discuss later, but it does not, like other coronaviruses, mutate rapidly. On average, it has about 2 significant changes per month. And none of these changes appears to be of great import with the exception of this one I'm talking about. So we have a relatively slowly mutating RNA virus. Well, what do we know about our immunity to this virus? Well, we have really 3 types of immunity. I've listed 2 here. We have what's called innate immunity. That is, it's a non-specific immune response when any foreign organism enters our body. We also have part of our immune response that requires education. That is, it requires experience with the virus or bacterium or any organism. And once it is educated, if you will, it starts to produce an immune response, either with antibodies, we call that humoral immunity, or by educating cells to kill the virus or kill the cell that harbors the virus. So that's our immunity. But the question is, what do we really mean by being immune? There's a couple of types of immunity. One is called sterilizing immunity. And this will be helpful for us when we think about vaccine efficacy. But sterilizing immunity would be like with the measles vaccine or with the oral polio vaccine. And that is, once we're vaccinated and we get sterilizing immunity, or once we've had a natural infection and have sterilizing immunity, the next time that same virus comes by and infects us or gets inside of our body, it can't replicate. Our immune system is too robust. The virus just can't get inside of our cells, can't replicate, which means, of course, we can't get sick, But it also means that we can't communicate that virus to somebody else. We can't transmit it. We cannot be a vector. That's the kind of immunity we really want. And as I said, measles vaccine does that. Measles natural infection does that. Polio natural infection and the polio oral vaccine do that. A second kind of immunity that is also very common, perhaps even more common, is what's called functional immunity. That means that once we're immune from a natural infection or a vaccine, when we get reinfected by that virus, it can multiply in our body, but it can't make us sick. And that's great for us, but it means that the person still could transmit the virus to somebody else. So functional immunity is great to keep us well, but it doesn't stop the transmission as efficiently as sterilizing immunity would. So I'll come back to these two ideas when we talk about the vaccines. Also, our immunity can be waning, and that is that it may get weaker and weaker and weaker over time. I mentioned with the human coronaviruses that cause the common cold that after about 1 to 3 years, our immunity is pretty much waned. And if we get infected with that virus again, we could get a cold again, maybe not quite as bad because we'll have some memory, but we still could get sick again. And then there are instances where we completely lose our immunity and we can get infected again. This is not common, but it can occur. To date, and to answer the question I raised about what do we mean by immunity, well, we don't know how long immunity from natural infection lasts. We don't know if it's sterilizing or just functional. We don't know if it wanes, or we don't know if we will completely lose our immune response. So these are terribly important questions that we still have to understand. Which leads us to the question, can we get reinfected? Can somebody who's had an infection with SARS-CoV-2 get infected again? And the answer is yes, but. The yes is that there are at least 8 now well-documented cases where people have had an episode of been infected with SARS-CoV-2 and become reinfected with a different strain. So we know it's a separate infection, not a relapse. The first case that was reported and well documented in the literature was a man from Hong Kong who had an episode, who contracted COVID-19, the disease, when he was in Spain. It was diagnosed when he came back to Hong Kong, and he got well, and he was only moderately ill, didn't require hospitalization. But then about 60 days later, he was being screened for infection because he had traveled out of the country again, and coming back, they screened him in Hong Kong, and he tested positive, although he was asymptomatic. And it was a completely different strain. So he was reinfected, but he didn't get sick the second time. The other case that is very well documented is the Reno, Nevada case. This was a young man, 25 years of age. And the first episode of COVID-19 was very mild. Because he had cold-like symptoms, he got tested and he was positive, but it went away very quickly. He was not sick at all. About 48 days later, he got sick again with classical COVID symptoms and signs, and he required hospitalization. Testing showed that he had COVID-19 again. And as with the first case, it was a completely separate virus, a completely different one. So these are 2 very well documented cases. And as I mentioned, there are 6 more. This is a paper published in October that had 4 documented, but since then there have been 2 more well documented. 4 more well documented. So we're at 8 cases. So the reason why the answer is yes, The but is that it appears to be very uncommon for this to occur. So at least in these 8 cases, we know that immunity was not adequate to prevent reinfection. So it can occur, but it appears to be very uncommon. Which brings up another question about immunity, and that is, what is herd immunity? We keep hearing about that. Well, herd immunity is a bad term because it means, it sort of describes us as being a herd, which is probably fine. We do have herd-like behaviors, but better names might be indirect protection or community protection or community immunity. I like this latter one the best, community immunity. It refers to the number of people that are immune within a population. And if that number is high enough, the virus can't find another host to go to replicate. After all, the survival of any life form on this planet requires the ability of that life form to propagate its species. And if there are no uninfected people, or not enough uninfected people around, the virus won't be able to go from an infected person to a non-infected person, and that particular virus will die off. And we know that I'll come in a moment to the number we need, but we need, depending upon how communicable the virus is, we need a substantial portion of the population to be immune. And this immunity can be obtained in 2 ways. One is by a natural infection. That is, we could just wait until we have enough people infected and immune and hope that that immunity is long lasting and at least functional, preferably sterilizing. Or we could vaccinate people. And the best guess in terms of what community immunity is for this virus is about 2/3 of the population. So we probably require somewhere between 60 and 70% of the US population to be immune, to really substantially get this virus away from us. Another way to look at it is that currently we think in the United States there's somewhere between 5 and 10% of the population that's been infected and should be immune. We don't know that for sure, but we think that's the case. If we say currently we have about 10% of the cases in the United States, this has caused about 230,000 deaths to date. We have, I think, 234,000 today, I think is the number. The herd immunity or the community immunity threshold is about 225 million. So if we say that we have 10% of the cases have caused 230,000 deaths, that means to get to herd immunity by natural infection, we would need about 22 times the number of deaths we've currently had, or over 5 million deaths in the United States. So those people, like this individual that counsels our president, Scott Atlas, advocating for herd immunity by natural infection. This is what, and what our current government is arguing for. This is the kind of numbers we would be talking about in terms of deaths. That doesn't talk at all about the number of people hospitalized, the number of people permanently damaged by COVID, all of those long-term side effects, none of that. So that would be how to get to herd immunity by natural infection. Needless to say, I'm a strong proponent of getting to herd immunity by vaccination. Another interesting question about this infectious disease is the question of, does the dose, in this case, does the dose of the virus make the poison? So one of my colleagues and just a wonderful infectious disease doctor at UCSF, Monica Gandhi, has been the major proponent of this hypothesis. The argument goes something like this. We've known since the 1930s that in studies that were done infecting people with influenza, that the more virus you gave them, the sicker they got. We wouldn't do those studies today. They would be quite ethically challenged. There have been studies with bacteria like Salmonella and Shigella that have shown the same thing. The more bacteria you're exposed to, the more likely you'll get sick. So there's clearly a precedent for this hypothesis. But we don't know whether it's the case with SARS-CoV-2. Some of the evidence that suggests it might be is that, remember the Diamond Princess cruise? Seems like years and years ago, but it wasn't that many months ago. They didn't put masks on people until very late in that outbreak. And a high percentage, I think it was 60% as I recall, but a high percentage of the people, both the passengers as well as the crew, became infected, and a high percentage of those folks became sick. There was another ship that cruise ship that we didn't hear much about called the Shackleton that occurred after that. And the minute they identified somebody on the ship, it was a crew member, the minute that person became sick, they gave masks to everybody. Still, a high percentage of the crew and passengers became infected, but a very low percentage of the crew and passengers became sick, suggesting that the masks decreased the amount of virus people were exposed to. We also know that in countries where there's a high percentage of mask wearing, the number of cases may rise, but the number of deaths fall. So again, this is not established. It's a hypothesis, but it's very intriguing. Well, let's get into some epidemiology now. How extensive is this pandemic? Well, these are numbers from this morning from the New York Times. Excuse me 1 second. The worldwide, we're a little bit above about 52 million people. These are reported. These grossly underestimate the actual number of people infected, but these are the number reported, and reported 1.2 million deaths, probably low by at least 20%. These are the numbers that are most disconcerting. A 25% increase in the last 2 weeks worldwide, and a 41% increase in deaths in the last 2 weeks. And this is the pandemic to date. Here we see the United States, 10.3 million, a 69% increase in the last 2 weeks. And now 240,000 deaths. It was 234 about 3 days ago. And 23% increase. And you can see where we're off to. This is California. We should be at about a million deaths either today or tomorrow. By the way, just before coming online with you, the United States today reported 140,000 new cases, probably reflecting yesterday's numbers. That's the highest we've ever had by far. And to put that in perspective, on June 1st in the United States, we were averaging 20,000 cases per day. And today we had 140,000 cases. So we're close to 1 million cases in California with 18,000 deaths, a 43% increase, but a 22% decrease in the last 2 weeks. Although that number is now starting to come up a little bit. I'll come back and address that in a moment. We've also had almost a 20% increase in hospitalizations. And this is the Bay Area. These are cases and these are deaths. This is from today, from the San Francisco Chronicle. The 7-day average now is right about here. So you see where we're going. This was back when we went into lockdown on March 16th and kept things flat. And then we opened things up in May and June, and we saw what happened in this terrible summer, primarily in Southern California. Then did the appropriate things again, and the numbers dropped. And now we're seeing it come right back up. And the same thing with the deaths. Although, as I mentioned, the deaths aren't doing nearly as badly in California to date as they have nationally. This is the Bay Area County. This is from the San Francisco Chronicle. This is from NBC, the local station NBC from this morning. And it shows you how we're doing. And we're going in the wrong direction. Contra Costa County is now in the purple. Marin County has remained there. San Francisco, almost 130% increase in the last 2 weeks. So we're experiencing the same phenomena that we're seeing in the United States. The reason why our numbers aren't nearly as bad is because we started with a much lower number of cases than the rest of the United States. And that's attributable to California doing a much better job than much of the rest of the United States. These are projections. This is from the University of Washington, their projections. This model up here is if people continue to wear masks, the percentage of the population continues to wear masks as they are currently doing. If that's the case, it's estimated that on February 1st, we will go from 240,000 deaths to about 400,000 deaths in 10 weeks. This lower line is if 95% of the population masked in the United States, we would be at about 310,000 deaths on February 1st. Or we could save about 90,000 lives in 10 weeks if people would just wear a mask. Are the death rates falling? And the answer is yes. Although currently they're going up a little bit, quite a bit, but I'll come back to that. So this is the United States, and this is back in 2018. And every year, most every year, 19 was an exception, most every year, influenza raises the death rate above the normal death rates that we see. So the black lines are what we would expect, and every year in December, January, February, and part of March, the numbers go way up and then come down. This is what we've seen this year because influenza is added to SARS in terms of respiratory deaths. And this was the first wave that we saw. And this was the second wave in the summer. And notice how the death rate dropped. This is Germany, and the top is the number of cases, and you see it come back up over here, but the number of deaths has not risen commensurate with the number of cases. So the death rate drops. Same thing for Spain, and same thing for the United Kingdom. So I think an interesting question that I certainly have, that lots of people have, and I'm sure you do too, is why? Why is it dropping? There's no evidence that the virus is becoming less virulent. So we have to look for other explanations. One of them, and I think a very important one, is that we've learned a lot better how to treat really sick people with COVID. And an example of that is San Francisco General Hospital, where the death rates are the lowest in the country. New York doctors are just as good as the San Francisco doctors, New York City doctors, but their death rates in their hospitals were much higher than the San Francisco hospitals in general, and San Francisco General Hospital specifically. That's because I'm sure you all remember the pictures of people on ventilators in the hallways because all the ICU beds were filled. Nurses and doctors were taking care of far too many patients. On the other hand, the hospital capacity in the San Francisco hospitals was much better because it was managed much better. And for example, San Francisco General Hospital, you would often have three nurses for two patients in the ICU, which one patient in New York City during the height of the pandemic would be lucky to, three patients would be lucky to have one nurse. So better medical care plays a major role in this. Perhaps the fact that people have been wearing masks, if Dr. Gandhi's hypothesis is correct, maybe that's playing a role. There are other guesses, but all we have is guesses now, but the data is fairly compelling that while still an awful lot of people are dying and will continue to die, the mortality rates are declining slightly. How is this virus transmitted? I think we all know much about this. I'll draw your attention to the middle part of this slide. The virus comes out of somebody's mouth or nose, and those droplets can be large or heavier than air, or they can be really small and lighter than air. And we expel both kinds. The larger ones, because they're heavier than air, fall to the ground within usually about 6 feet. You can't really go much further. The really small ones can remain in the air for prolonged periods of time and go much further than 6 feet. Those large droplets can fall onto somebody else's nose or mouth or eye and get inside of our body, or they can be on somebody's hand and be transmitted to somebody else. So my hand touches somebody else. I now have the virus on my hand. I touch my mouth, nose, or eye, and I inoculate it. Or those droplets could fall onto inanimate objects that we could then touch, have on our hands, and inoculate ourselves. So of these methods of transmission, small droplets, larger droplets, direct contact with people, direct contact with inanimate objects, the far and away, the most important are larger droplets. This accounts for the vast majority of cases. There are documented instances where it's pretty convincing that these really small droplets can also spread, particularly inside a building as opposed to outside. There's just too much dilution outside. But inside a home, for example, or an office building, this would be where it could happen. But this is much less common than this. And we don't know how important this is, but we think this is the least important. I'm not telling you to stop washing your hands or using alcohol on your hands, but that's terrible. We think that's important, but we don't know how important. We think it's the least important of those. This is primarily a respiratory transmitted pathogen. Two other things associated with transmission that need to be addressed. One is the fact that asymptomatic spread does occur and pre-symptomatic spread occurs. Let me define this. Asymptomatic essentially means that I got infected right here, and within a few days, I had enough virus replicating in my nose and mouth and larynx to spread this virus, but I have no symptoms. And there's enough virus to spread this for about 10 days in me, but I have no symptoms. I don't know I'm infected because I'm asymptomatic. This accounts for probably more than half of all the cases that are transmitted in the United States. Not because asymptomatically infected people are more contagious, but because when people aren't sick, they don't take the same precautions that people should do and usually do when they are ill. There's another instance that's worth talking about in terms of transmission, that is pre-symptomatic spread. I got infected right here, and then usually about 4 days later, but it could be 3 days later, rarely more than that. I'm contagious, but I don't know it. I'm completely without symptoms, but then I become contagious. So people can spread it before they become contagious. Usually a day, maybe 2, 3 would be very unusual. So transmission can occur asymptomatically or pre-symptomatically, and certainly it can occur when people are symptomatic. So when are we contagious? I already addressed that a little bit, but this shows it in a different way. I draw your attention just to this dotted line right here. Forget about this other line. And here's the day that we become symptomatic, day 0. Here's the day we became infected. And this reflects virus replicating in our bodies. And notice that the peak amount of virus replicating in our bodies occurs about a day before we become symptomatic. So about a day before we become symptomatic, if we ever become symptomatic, is when we are most contagious. Influenza, which is not as contagious as this virus, but very contagious, can be spread before people become symptomatic by about a day. But the amount of virus that they have is very low. The peak amount of virus they have occurs with the development of symptoms. So that has a tremendous import in how this virus spreads. Because if I got influenza, and I suspect all of you have had influenza, it knocks you off your feet. You're not going to go to work. At least you certainly shouldn't, and you're not going to feel up to it. So when I become symptomatic from influenza, at that moment, I'm in bed. And that's at the time of my peak contagion. If I got SARS-CoV-2 infection, a day before I become symptomatic is my peak contagion. I'm going to go out and do things. At least most people would, even though perhaps they shouldn't. So that's the important point with that slide. Is there a seasonality to this virus? Our president certainly told us there was going to be, in his infinite wisdom. The answer is obvious. We know the virus does very, very well in winters. All coronaviruses do very well in winter. But this virus, as we know from this summer, did very well in the summer. So it probably will do better in the winter than the summer, but it does fine in the summer. So the answer is not much. What is the natural history of infection? By that, I mean, what happens if you get infected on average? Well, 70 to 80% of people either have an asymptomatic infection, that's about almost half of this group are asymptomatically infected, and the remainder gets sick, but not sick enough to even necessarily be, certainly not sick enough to be hospitalized. They may seek medical care, but not sick enough to be hospitalized. 15 to 25% get really pretty sick and require hospitalization. And about 5% require the intensive care unit. And originally, early on, it was about half or 2.5% of the people in the ICU would die. That number is now down to, well, the latest numbers at San Francisco General Hospital are it's down to 18% of people on a ventilator die. So it's really gotten a lot better. That's the natural history. What are the long-term consequences of getting infected with this virus? A lot of things. This is a study from JAMA in July that looked at people who had COVID infection. Some of these people were quite sick, some were moderately ill, some were hardly ill at all, and some were asymptomatically infected. And they looked at these people 60 days later. And these are the symptoms during their acute phase over here, the dark green, and the lighter green is 60 days follow-up. And at 60 days, about almost 60%, 55% were still complaining of fatigue. About 50% were complaining of shortness of breath. 25% joint pain, about 20% chest pain, about 15% were still coughing, about the same still couldn't smell. They lost their sense of smell. That's called anosmia, and so on. So we see that these were 60-day complications. We have more data now to suggest that, for example, most people with anosmia, it goes away usually after about 90 days. Permanent loss of smell appears to be unusual, but we do have some people who are out to 10 months, and that may be permanent. This fatigue associated with this brain fog that people talk about appears to be quite common and quite persistent. So this is of great concern. There are also events that occur during the acute infection that cause permanent damage to people. Lungs become scarred. I talked about fatigue. Strokes can occur. Heart attacks can occur. Blood clots can form in multiple parts of the body. And there's one other thing I wanted to mention. There's increased morbidity and mortality from other diseases. And we tend to not think about that as a complication of COVID. But we've seen, particularly in the spring, that the number of people dying at home from diabetes out of control and the number of people dying at home from heart attacks dramatically rose because people were afraid to go to the emergency room and afraid to get medical care. There are multiple other examples of that. There's also another longer-term concern that people have not been getting the preventative care that they need, particularly in terms of cancer screening. And there's a great fear amongst oncologists that we're going to be seeing a rise in both breast, prostate, and colon cancer. What about children? We hear a lot about children in terms of, can they get sick? Can they infect other people, and so on? One thing we do know is that the numbers have been rising, and there's been also a slight rise in the number of deaths in children. Although that said, deaths in children below the age of 10 or 11 are extremely rare. There is that unusual immunologic syndrome that's extremely rare called multisystem inflammatory syndrome of children. We know, though, that children between the ages of 11 and 18, and having grandchildren, one grandchild who's 18, I consider them still children, they appear to get infected pretty much at the same rate as adults. So it's primarily children less than 11. This is just one of two studies I'll show you. Children less than 11, this is less than 10 in this case, don't express that ACE2 receptor as much as people between 10 and 17 or older. So they don't have as many receptor sites for that virus. And they don't shed as much virus as people in older groups. So this is an argument that is not an unreasonable argument to say that children 10 or less are probably not a major risk in terms of magnifying the viral spread throughout the community. And they're very unlikely to get sick or die at least, and less likely to get sick. And we know the consequences of not being in school are tremendous. So while that still remains a major debate, particularly for younger children, there can be an argument can be made, and I'm happy to discuss this further. An argument can be made for putting them back in school if the prevalence in the community is low enough, and that's a big if. So how is this disease diagnosed or infection diagnosed? This is the dreaded nasopharyngeal swab, or the NP swab, where it goes all the way back to the back of your throat. This is what's called a mid-turbinate swab. It goes in about an inch through your nose. This is right at the tip of your nose, and this is saliva. Right now, the gold standard is the NP swab, but it's not practical because the person doing it has to be in very careful protective garments, masks, and so on, eye shields. And it's very uncomfortable moderately uncomfortable for patients. most people are doing the mid-turbinate swab, which is almost as good as the NP swab. The anterior nares swab is good, but not as good as these two. The saliva, we don't know yet. Most of the data that we have suggests it's probably not as good as at least the mid-turbinate or nasopharyngeal swab. It may be as good as the anterior nares. There are three types of tests you hear about. The RNA test, and it's either done in the laboratory or now there are rapid RNA tests that can be done on site. There's the antigen tests. Those are usually rapid tests that are done on site. And there's an antibody test. I'll be happy to dilate on all three of these, but let me just say a couple of pithy things about each one. The gold standard is the RNA test done in the laboratory. The rapid test for RNA is done, can be done on site with the machine. That's the test that's been done in the White House. Needless to say, with the two outbreaks that have occurred in the White House in the last 6 weeks, we know how effective that test is. The antigen test is what, for example, the Pac-12 is using for football players right now. It's done daily. It's much less expensive than the RNA test. It's also much less sensitive, and it does have some false positive tests as well. And the antibody test is, at this point in time, not worth your spending money on. People were all excited about it, and disreputable laboratories were marketing it heavily in the spring, saying if you have a positive antibody, you can't get it again, so you're home free. Well, we don't even, as you now know, we don't even know about immunity, so how could they make that claim? So right now, antibody tests are not worth getting, so please don't throw your money away. That said, we will have antibody tests that will be very helpful to get in the, I think, near future. Fingers crossed. So how do we treat COVID-19? Right now, we have 2 approved treatments for people who are hospitalized or very seriously ill in the ICU. There are no approved treatments for people for prophylaxis or for people, should be prophylaxis or at risk, or for people infected or people who are symptomatic but not very sick. The drugs that we have that are approved are remdesivir and dexamethasone. Right now, we have, these are the 2 that are widely used. We have a couple that are very promising. I'll come back to that. We have some where there's mixed evidence, and we have some that are just absolute fraud. Think Trump's favorite drug, hydroxychloroquine. No evidence at all that it works. So in looking at the variety of drugs that we have some drugs that are antiviral. One of the drugs that's approved is remdesivir. Right now, it can only be given intravenously, so you wind up having to be sick enough to be in the hospital. But we know that for an antiviral to really be effective, you have to take it as quickly as possible once you become sick. And that's what we do with influenza. You need to call the doctor right away if you come down with a high fever and a terrible cough and body aches, because we have 3 drugs that can treat that, but you have to take it very quickly, preferably within 48 hours, preferably within 24. Right now, the company that makes remdesivir, Gilead, here in the Bay Area, is working on an oral spray where you can inhale it with the drug. And if that becomes available, if it proves to work, it would be pretty much a game changer, because people could use it the minute they develop symptomatology. And fingers crossed that that would work. But right now, we can only give it intravenously. Trump received these monoclonal blocking antibodies, and one of them just was approved, at least got an emergency use authorization yesterday or the day before. But we lack double-blinded control studies to see how efficacious they are. Convalescent plasma got an EUA before there were any double-blinded control studies, and most of the data that we have, albeit preliminary, suggests it probably is not very effective. So we need double-blinded control studies. Dexamethasone is the other drug that's approved. It's a corticosteroid. It's like prednisone. It's been shown to decrease death, not tremendously, but it decreases people who are very, very sick, oxygen dependent, who get this, and their mortality rates do drop. So it definitely should be given in that setting. Remdesivir, the studies have shown it does not decrease death, but it shortens hospital stay for those people who are quite ill from 15 to 11 days. How do you prevent getting infected? Well, wash your hands. This virus has a fatty coat called a lipid coat around it that is destroyed by soap, which is unusual for viruses. So wash your hands with soap and water 20 seconds. Do that often. If you can't wash your hands, use disinfecting alcohol solution, at least 62% or more. Social distance, please. This is from Memorial Day in the Lake of the Ozarks. Many of you probably saw that. And this is on Costa Brava of Spain in the midst of the pandemic in August. Absolutely nuts. Wear a mask. This was Arizona. Their Trump-loving governor would not allow, forbade cities to mandate mask wearing until it got so bad there this summer that he was forced to do that. Once he was forced to mandate it for the state, the numbers, this you can see right here. Staying at home, wearing a mask, numbers dramatically drop. This is not rocket science. This is data that supports what I was saying earlier. This is the percent wearing masks every time you're in public, and these are the current cases of COVID. And you can see the fewer the people wearing masks, the more new cases you get. So it's absolutely clear, the science is unequivocal, that wearing a mask protects other people and protects you. Social distancing protects you and protects other people. Education does not appear enough for the American public. Over 80% of the people understand all these things that I'm talking about. But Americans don't seem to respond as well as they should. Most do, but too many don't. And that's why this continues to spread so widely. Let me just pause for a moment and tell you how well America has done with this pandemic. We have 4%, approximately 4% of the world's population. We have approximately 20% of the world's cases and 20% of the world's deaths. That's how well the United States has done. Contrast that with Taiwan, Japan, New Zealand, Australia, Singapore, South Korea. This is unconscionable. This was a mathematician who came up with this data and published it in August. His argument was that people aren't going to really respond until they know someone who's died of COVID. And then once you've known someone who died of COVID, then maybe you'll take it more seriously. And he estimates that, I don't know, I can't critique his data, but he estimates that the average American knows about 600 people. And this would mean that about 500,000 deaths from COVID would have to occur for every American to know someone who's died. That's assuming there's an equal distribution of the cases throughout the population. And we know that's not the case. We know that cases are maldistributed in terms of being far more common in Black and brown populations, and that correlates with socioeconomic status. So that's why Black and brown population in our country know very well and are quite fearful of COVID. Yet people who are more privileged in our society, which tends to not be Black and brown people, often don't know someone who's died of COVID. And until you do, a lot of people just won't respond appropriately to this pandemic. What's the status of vaccines? Well, typically, on average, it takes about 11 years to develop a vaccine. We're going to have one in less than a year. probably, unless there's some surprises. Right now, we have 11 vaccines worldwide in large-scale studies. 6 have been approved worldwide for limited use, China and Russia primarily. None have been approved for full use. There is a bunch in trial. So we've got a lot of vaccines to look at. The phase 3 trials, the ones in the United States, are these that are listed here: the AstraZeneca one, the Janssen one, the Pfizer one that we heard about from Audrey, and the Moderna one, which is very similar. It's the same mechanism as the Pfizer one. I put the star here because that's where we have some data. So I'll just tell you a little bit about this right now, because I'm sure there'll be questions about it. Pfizer has enrolled about close to 44,000 people so far. They plan on enrolling 66,000. They have immunized around 39,000 people. Well, they have either immunized or given placebo to almost 40,000 people. The placebo dose is given on day 1 and day 21. The vaccine dose is given on day 1 and 21. It's double blinded, so the people don't know what they're getting, and the people giving the vaccine don't know what they're giving. The code was broken a few days ago, on Friday actually, to look at what was happening, because 94 people who had either received the vaccine or placebo developed symptomatic COVID. We don't know how symptomatic. We don't know if they just had a runny nose and a sore throat, just lost smell, or whether they were hospitalized on a ventilator. We don't know any of that data. None of this has been published. This is all a press release. This seems to be how we're learning about things today, not peer-reviewed published literature, but press releases. But in any case, of the 94 people, when they looked at those people, 9 of them, we think the number is 9, because they didn't give the exact number, but they said 90%. 9 of the people who got sick got the vaccine. 85 of the people, we think, got the placebo. That's how we got to 90% efficacy. We don't know if it's functional immunity that they got or sterilizing immunity. It's probably functional, but we don't know. And we don't know how long that immunity will last. But we do know that only 9 people out of the 94 who got sick, and those are the ones that got the vaccine, and 85 who got sick didn't get the vaccine, they got placebo. So that's very compelling data. Recall that the FDA said they would approve a vaccine if it was 50% efficacious, and this data suggests 90%. They're going to take another look when they get to 164 patients with COVID and see what the numbers look like. I wouldn't be surprised if that 90% efficacy drops, but still, this is pretty remarkable. It knocked the socks off just about everybody who's been thinking about this. So fingers crossed. There's a lot of unknowns, and we can talk about that, about vaccines. And who's going to get the vaccine? It's going to be tough. This is a formidable logistical problem. The vaccine has to be held at a very, very cold temperature, something very few freezers can do. Certainly maybe some hospital freezers can do that. Some selected freezers in industry can do that, but it's very difficult. And how are we going to transport the vaccine, keeping it that cold? So there's some real formidable issues there. There's also the problem of it requires 2 doses, day 1 and day 21. And we're talking about immunizing millions of people. So there's some boulders in the road, but we can manage that. I mean, we can deal with it, but it just has to be done professionally and done well, but it can be done. The first people who are likely to get the vaccine are going to be the first responders and people who work in the healthcare facilities. That makes a lot of sense. Also, people who have a lot of underlying conditions that put them at very high risk, and older adults who live in congregate or overcrowded settings. So it sounds like for Ashby Village, and for me, we would be talking, we'd probably be in phase 2, or older adults, not living in congregate settings. So we'll probably be in the second phase, along with the others that you see listed here. And then we'll get to phase 3 and phase 4. By the way, the Pfizer vaccine was only studied in children down to the age of 16. So we don't know about younger children. The best guesstimate that I have is by the time everybody in the United States who wants to get vaccinated will get vaccinated, it's probably going to be close to this time next year. And governmental controls. The only thing I'd like to say about governmental controls, we tend to not pay as much attention to that as the other kind of controls that I listed, like social distancing, masking, and so on. But the numbers I told you about how the United States has done, the reason why we failed is because we've had not only no central government control, no national government control, but we've had quite the contrary. We've had prevarication on multiple times a day. We've had the politicization of the FDA and the CDC, so people have trouble trusting what comes out of those organizations, even though the senior scientists there are absolutely outstanding, but they've been muzzled. We have mistruths about masking and social distancing. Think these big rallies that Trump held and all of his energy about demonstrating that he doesn't need to wear a mask, and all the outbreaks in the White House. And also, we have no modeling. We need a president who will model what American people should be doing. If we had better leadership, we would not have had nearly this many deaths. I feel very comfortable saying that Donald Trump has blood on his hands for this. So what's going to happen? I don't know. It's going to continue. We're not going to wake up one morning and this is going to be gone. The vaccine is not going to mean that it's all over. We're going to be wearing masks and social distancing for a long time. But I'll leave you with this. When Pandora opened the box, she let out all the evils of the world, and she realized what she was doing, and she slammed it shut. And one thing was left in the box, and that was hope. So I'll leave you with hope.
Gee, thanks.
Sure.
Thank you very much, Dr. Swartzberg. So now I'm going to unmute everyone, but you must promise to be behaved, not interrupt one another. You know, I'm going to read the questions, and if I'm reading your question and I didn't read it right, then please raise your hand, you know, either like this or on your little participants thing that says I'm raising my hand. So we'll start with the first one. Some news comment. Oh, I didn't unmute everyone, so I have to do that. Oops. Well, everybody unmute themselves. Can you do that? Nope. Oh dear. Well, we'll have to go one at a time then. Some news commentator said New Zealand's Prime Minister Jacinda Ardern competently handled the coronavirus pandemic. What did she do, and why can't we do what she did?
So the things I was talking about, she did good modeling, not just her, but public health in general. They pushed masking. They insisted on masking, and they did social distancing. Now, New Zealand has an advantage over the United States. It's obviously a much smaller country and a much more homogeneous population. But still, that's what she did. You know, I was talking to a journalist in Japan a week ago last Sunday, and she was asking me a bunch of questions. And at the end, I was just chatting with her about, I said, Japan's really done remarkably well. Japan's had around 2,000 deaths since this pandemic began. Now, it's a smaller country than the United States, but 2,000 deaths. Think of a city like Tokyo. So she said, you know, what happened there was that early on in the pandemic, the prime minister and the politicians were managing the pandemic, and very quickly they realized that they were over their heads, didn't know what they were doing, and they needed, and it really was not something that should be managed by politicians. It had to be managed by public health professionals. And they turned it over to the public health professionals in Japan. And all the pronouncements, all of the regulations, everything that was done in Japan was through public health. They did a tremendous job. The United States did the complete opposite.
Thanks. Let's see, I have another one. Can you speak the false negative rates of the Abbott rapid test used at, for example, Go Health Urgent Care in Oakland versus the curative PSR test in Berkeley?
No, because I don't have those numbers in front of me. But the rapid RNA testing, which both of those are, they have a false negativity rate of, well, the published false negativity rate is around 1.5% to 2% for most of those tests. The real negativity rate, when it's applied to the real world as opposed to the laboratory testing, is lower than that. And the reason for that, it depends upon when you're tested. You don't really develop a detectable amount of virus in your nose or throat until at least 3 days after infection. And typically it's about 4 or 5. So sampling people's nose or throat before day 4 or 5, you're probably going to get a negative test. It's not really a falsely negative test. It's just negative because the test is not that sensitive. It can't pick up so few viral particles. So it depends upon the timing of when you get it.
Mm-hmm.
I hear lots of people, they'll ask me, you know, I was exposed to somebody yesterday, should I get tested tomorrow? No, it's going to be negative. Even if you got infected, you have to wait. Actually, the best, if you have to pick one day, if you could only get tested once, it would be day 7 or 8 after exposure. That's where the highest yield of all these tests is. But in somebody who has a lot of virus, both of those tests are probably at least 98%, maybe even higher, sensitive.
Linda, did that answer your question?
I got a little confused because there was some background noise. Hi, John. I'm wondering if I've heard that the negativity rate with the Abbott can be quite high if a person is asymptomatic when you go to get tests. Say you're trying to get tested in order to be able to see someone, but you haven't been exposed or that you know of, or you're not symptomatic. So isn't there a difference in those rates?
Yeah, it's really interesting. You would think that people who are asymptomatic shed less virus than people who are symptomatic. And the studies on that have been mixed. Some studies have shown that to be the case, that you have less virus if you're asymptomatic than symptomatic. But other studies that have been very well done have shown that whether you're asymptomatic or symptomatic, you shed about the same amount of virus.
Mm.
So the answer is we don't know.
Okay. So let's see. Andra Lichtenstein says, are you saying that it is not a big risk to see our grandchildren under 11 years old?
No. I've got a grandchild in Oakland that's under 11 years old, and I haven't hugged her since March 10th.
And you haven't gotten sick?
We do see her. We go in the backyard and we wear a mask and we socially distance, and they wear masks. And we'll have dinner there, but we'll be probably 8 feet away, not 6. But,
Mm-hmm.
but no, I'm not saying that. Kids can spread this. They probably don't spread it as efficiently. Most of the data suggests they're not nearly as efficient as we have a 13-year-old in Oakland too. And she's probably a more efficient spreader than the 10-year-old. But that's more out of interest. I wouldn't put yourself at risk thinking that you could be with a 5-year-old because it's safer.
I was just interested because you said that kids don't have those receptors or they don't have as many. And so it was,
Right.
it, so what's the percentage of kids do we know that get it?
Yeah, children less than 10 are less likely to get infected, but they still do get infected. They're very unlikely to show any signs or symptoms.
Uh-huh.
But we don't know who those kids are who are infected and not infected. That's why you just can't do it. My 10-year-old I'm talking about, she just went back to school Monday. And so now I'm really not going to be really more careful around her.
Yeah.
This is just one of, for people our age, this is just clearly one of the most painful aspects of this pandemic. We have 2 children, one in Oakland and the other child is in on the East Coast near DC, in Arlington, Virginia. And we haven't seen, and she's got 3 children, and we haven't seen her husband or the 3 grandkids. It'll be a year next week. It was for last Thanksgiving. And we don't know how to get back there, and we don't want them traveling out here.
Another question. Some MDs from a few prestigious universities have recommended that all healthy children and adults under age 55 who do not have underlying conditions go back to school and to regular unmasked lives in order to reverse the terrible psychological effects that the total shutdown we are experiencing now is producing, especially in young children.
Yep.
Bad idea?
They are from prestigious institutions, and some are MDs, some are PhDs, or some are MD PhDs. I actually debated the MD PhD from Stanford on the radio about 2 Saturdays ago. This is what has been called the Great Barrington Declaration that I'm sure many of you have heard about.
Nonsense.
Great Barrington is, I had never heard of it before. It's a small town somewhere in New England. There's nothing great about Barrington. It's a small town in New England. That's where these 3 people met to write this declaration. And then they got a lot of other people to sign on to it. Audrey actually asked me about this and said, I'd like me to discuss it. So I will be happy to discuss it. But I hate to give it airtime. The reason why I feel so strongly about this is they're essentially saying that let's take people who are at high risk for complications from the virus or dying from the virus and keep them away from everybody else. So that means all of us, everybody over 65, it's a lot of people. And it means everybody with diabetes, everybody with chronic obstructive lung disease, everybody with, just name all the other chronic diseases that put obesity. There's a long list of people who are at increased risk of death, substantially increased risk of death from this virus. Most estimates are that's about 40% of the American population. So we're going to take 40% of the American population and put them in their own home. But wait, there aren't, some people live with families where there's grandma, mom and dad, and kids. What are we going to do with grandma and grandpa? Well, they're going to have to go somewhere else. And we'll have to figure out how to do that. So we're going to all be put somewhere. If we have our own home, if we're lucky enough, we can stay there. And we're going to have to figure out how food's going to get to us and other things. And we're going to have daily teleconferencing with our therapists to help us get through this. So that's the plan. And for the remainder, or the 60% of the population that's left here in the United States, they'll go back to work because they may get infected. Some of them may get sick. Some of them may die. But we'll get to herd immunity very quickly. That's what this one of the supporters of this guy I mentioned, also from Stanford. Person I debated was from Stanford, I think I mentioned. And for full disclosure, I did my infectious disease training at Stanford, so I'm not beating up on Stanford. But this guy, Scott Atlas, who has absolutely no business advising anybody about how to manage this pandemic. He's a big supporter of this idea. Let's get to herd immunity quickly. Well, 60% would be the lower limit of people who had to get infected to get to herd immunity to have herd immunity. So we're between 60 and 70, as we discussed. So how many people are going to die getting there? I already showed you. The numbers are going to be enormous. It's not, it doesn't work on a practical level. It doesn't work on a psychological level. And I think it's immoral that they're suggesting. They do make some very good points. These are not stupid people. These are very smart people, but they see the world differently than I think most public health physicians do. Perhaps I can best illustrate that by just telling you one thing. The group at Stanford that supports this, including the person I debated, receives considerable funding from Charles Koch. I rest my case.
Well, thank you for addressing that. I have some more questions, so I really want to get to those before I beat on this dead horse. But it says, will people who tested positive, were treated, and recovered be able to receive the vaccine?
I don't know. I'm not sure. I think the answer will be yes, but I don't know that.
Okay. Are there any genetic markers for greater risk with COVID-19?
No. There was a tantalizing paper trying to explain why African Americans have higher rates of infection and higher mortality rates. And it suggested that there may be a genetic predisposition, and it had something to do with the ACE2 receptor. That data has never been confirmed, repeated by other researchers. And to my knowledge, there hasn't been anything else that has suggested a genetic predisposition to death. Earlier on, there were papers that suggested that type A blood, people with type A blood were at increased risk. Some papers have confirmed that, other papers have not shown that, so we don't know. There may very well be some genetic predispositions, but basing that on ethnicity is fraught with problems because we know from genetic studies that African Americans their genomes are much more similar to ours, to white Americans or to brown Americans than they are different. And oftentimes the genomes of white Americans, for example, are more different than between a white and a black American. So we don't, I think there's just not enough data to say that any one of us is at increased risk of getting infected or dying because of our race or ethnicity. It may turn out that there are some things that we learn, but right now we just don't have that science.
Okay, thank you. Alan Griff, you said you had a couple of questions that you didn't write. Ask one, if you would. Alan, can you hear me? Can you turn up your volume?
I think he's muted.
We can't hear you. Sorry. Well, I'll go on to someone else, and when you get your volume up, that will come back to you. Okay. Let's see. No, I think I've gone through all the questions. If I did not ask your question, would you raise your hand? Monroe, would you unmute yourself? Charlie, you have one.
Okay.
Yeah, I'm concerned about this idea that the viruses just hang around on various surfaces as well as float in the air for a while. And it makes you very insecure that you don't know that when you're going to get infected by just touching a doorknob or walking past someone. What's the latest understanding of how long that stuff persists in an active form?
Yeah, we do have some data, not a lot, but we have some data that shows, depending upon the type of surface the virus is on, will determine how long the virus is viable. For example, on paper and cardboard, well less than a day. On metals, less than 48 hours. On plastics, less than 72 hours.
That's very scary because that basically means everything you bring into the house you need to wipe off with Clorox or something like that if it's going to be a day or more that it's actively infectious.
Right. Well, it is, I agree with you. The problem with the studies that have been done is they do tell us whether they can find live virus for how long on what particular object. But what they don't tell us is how much virus is there and whether there's enough to cause infection in us. And I think that's the key thing. One of the things that we don't know, and it's a critical thing we need to learn, is what is the infectious dose of this virus? How much virus do you need to get exposed to? Is it 100 viral particles? Is it 1,000? Is it 1,000,000? Or is it 10 million? We just don't know the answer to that. And until we know that answer, we don't know what to say about these inanimate objects we touch. So here's what I would say. I think the risk to inanimate objects is low. Everybody has to determine their degree of risk tolerance. If you want to mitigate the maximum amount of risk you can in terms of touching things, then you should wipe off everything you buy at the grocery store with a disinfectant wipe. It's easy to do that. You should put food that you have that other people may have touched that you can wash, you should wash it off, soap and water. Otherwise, hopefully it's like apples that you could put in the refrigerator in a bag that has not been contaminated and leave it there for a few days. That's what you could do with your mail that comes. You could put it on the floor and wait 24 hours before opening it.
Yeah, I've gotten sloppy about the mail. I tend to wipe off the mailbox before I open it with a Clorox, Kleenex kind of thing. But then the mail is sitting there on the counter inside calling to me.
I know. You know, I know people who are even more obsessive than I've just outlined, and I know other people. One of my colleagues at UC Berkeley, infectious disease specialist, just like I am. He's a brilliant guy, and he doesn't bother with anything you touch. I'm not quite there yet. My wife is more anxious than I am, but I'm more towards her than towards him. But so everybody's different here. The risk is not great, but if you want to mitigate risk, those are some things you can do.
Yeah.
Can I ask a question?
Yeah.
My question is a very practical one.
Where are you?
I'm here. I'm in Berkeley.
Oh,
On the
Monroe.
South Berkeley border, yes. My question is a practical one. At what point, as far as I know, we're both negative in the household. We've been protecting ourselves when we go out most of the time. We are talking about bringing in a house cleaner again. Don't know anything about whether or not she has been tested. Even if she wears gloves and a mask, is that a good idea, or should we postpone that even further?
Again, I'm going to frame it the same way as I framed the other, and that is how much risk you want to mitigate.
Yeah.
We have a husband and wife who have been kind enough to clean our house now for 20 years. And they haven't been back in our house since March, second week in March. And every month I just send them a check. Okay, so my wife's not around now. So if it was up to me, I'd have them come back. I'd open the windows, but it's getting cold now, but I'd open the windows while they're here, and I'd ask them to wear a mask and gloves. But I think the risk is exceedingly low. I can tell you that my wife would not be happy hearing me tell you that. So everybody has a different risk tolerance to this.
Yes, I'm the public health trained person. I'm backing away from having her come for a while. My wife is like, you.
I will tell you one thing to think about, and it's just not only to house cleaners, but I think I mentioned to you on June 1st, we were having 20,000 new cases a day. And now, yeah, I did, because now today we had 140,000 new cases. The amount of virus in our community, the amount of people shedding virus now and transmitting it is 7 times more than there was in June when we were being careful. So it's probably 7 times riskier right now than it was in June, on June 1st. So, you know, everybody's getting COVID fatigue and wants to be doing things, but frankly, if you're going to be careful, it's much more important to be careful now than it was in June and May. That's the bad news.
Thank you very much.
You know, Alan Alan, are you ready to speak to us? Nope, we can't hear you. Oh, you're not, can you unmute yourself, Alan? You're muted.
We can't hear you.
Oh dear. There you go. Okay, now try. Alan, we can't hear you. I'm sorry. Can't hear you. Sorry. Okay, is there I'm sorry, Alan, but can you write your question and send it in? We can't hear you. So is there anyone else who has a question? Linda has another question.
No, there we go.
Okay, on chat.
Yes, please. John, there's been a lot that's been written recently about new guidelines for congregating outdoors in groups. But there are people I know who have had this idea that if, for example, around the holidays or any other time, 8 or 10 people from the same family, but in, say, 3 different households, quarantined for 2 weeks and then got tested right before the event. Is that a plausible way for people to safely get together?
Yeah, except you don't need to get tested. If you can absolutely trust those people, quarantine for 14 days, then there's no way they're going to get infected. So there's no reason to test. You could get together.
Well, that would assume like a perfect quarantine as opposed to people still having to do a few different grocery store. Right.
Therein lies the rub.
Yeah.
That's the problem.
Would testing help under those circumstances?
No. The reason why is because if you get tested today and you're negative, 12 hours later, you could be positive. Remember, we talked about how long it takes for the virus to be present and the false negativity. So I think people are using testing to comfort them, but it's not really helping.
So let's say they quarantined for 2 weeks and then we're inside. Would they still need to be wearing masks?
No.
No.
You just have to trust that people are quarantining.
Okay, thank you so much.
Yeah.
Okay, I found Alan's questions. He comments that the social appeal of risk, especially among young mating dating age, can be understood. Then he says, olders have become less useful to survival. See Margaret Mead's Culture and Commitment from 1969. Would you care to comment on those quotes or those comments?
Not really. I mean, they're not really questions. They're
Right, they're just comments. So
for them.
No, he said.
does anyone else want to respond to that? Okay, well, is it safe to say that we have exhausted our supply of questions?
I got one more question, Audrey.
Oh, okay.
Yeah.
Charlie, go ahead.
In terms of being outside near people where there is some breeze blowing, you think it's reasonable to assume that we'll undoubtedly pick up some viruses, but they're going to be pretty diluted with a breeze constantly blowing things around?
Yes, absolutely. But I would still wear a mask and socially distance.
Yeah. How about no mask, but stay 10 feet or more away?
I think that's safe.
Okay. At best we can breathe.
Yeah, I think if you have any question, it's always so easy to just put a mask on.
Thank you.
Well, thank you very much. I have a few more things I'd like to say. One of them is that Ashby Village has allowed us to start our walking program, and we are keeping our group size to 6 people. You can register for those walks as you see them on the calendar. Let's see, our next one will be on November 23rd. This session is being recorded, still is being recorded, and you can find the recording on the YouTube channel of the Ashby Village website. If you're not familiar with that, you can go to the posting for November 11th about Science and Ideas, and on that posting, down at the bottom of the description, there is a link that you can go to get the recording. Now, it won't be ready for posting until tomorrow, probably, but we are recording it. I must say, I was expecting to have a helper who was going to help me remember to record, and so I got it started a little late, but we certainly got most of it. My apologies. Is there anything else that needs? Wait, there's a person. Natalie. Yes, Natalie.
Yes, I'd just like to refer everyone to the Monday session through Ashby Village and North Oakland Village on people dealing with the stress of COVID and all the other stresses that are going on, some of which have been slightly relieved recently. But I can't remember the time, I'm sorry, but it's there's going to be a talk and then some small group sessions to discuss people's methods for relieving stress and getting some ideas and helping each other out. So it might be good. I think it's in the morning, but just check your calendar for your Ashby Village calendar for Monday.
Thank you, Natalie.
Thank you.
All right, is that it for those of us remaining? Okay, thank you again.
Thank you. That was a really interesting presentation.
Thank you, if you can hear.
Thank you so much.
Thank you
Thank you, Dr. Swartzberg. That was awesome.
Thank you.
Thank you. Okay.
Bye, everybody.
Bye.
Thank you.
Yeah, thank you.